Very, very happy to be here with you to discuss in this first talk gas exchange in patients with respiratory failure who are on VV ECMO support. This is my disclosure slide. So first of all, and this is going to apply to both of my talks, we're going to use this revised definition of what is ECLS. ECLS was a term which was used in the past for mostly cardiac support, but now ECLS is an overarching term covering both ECMO and ECOR. And when looking at those machines which provide ECMO support, we have ECMO for cardiac failure is going to be the topic of the second talk. ECMO veno-venous ECMO for respiratory failure. This is the focus of this talk right now. And there is a hybrid form of ECMO. I will talk about that also in the second talk for very specific indication. And apart from ECMO, we have ECOR, which provides some CO2 removal with very limited blood oxygenation. We have developed that in a recent JAMA review paper with Dan Brody and Art Slutsky. And this is how venous ECMO works. The blood is drained from the right side. Most frequently, the drainage cannula is advanced here to the right atrium. The blood passes through a pump and then is propelled through a membrane oxygenator where gas exchange occurs. This new generation membrane oxygenator, they are made of PMP, polymethylpentene fibers, hollow fibers, and the blood goes around these fibers while the gas flows through the fibers. And there is gas exchange occurring between the gas phase, which is in the fibers, and the blood, which once again is flowing around. The oxygen goes into the blood, and carbon dioxide goes from the blood to the gas phase, where obviously there is no CO2 against a concentration gradient here. It's a passive mechanism. So it's also very important to have in mind the level of oxygen and CO2 transfer through this membrane. And it's around 20 to 25 times easier to get out the carbon dioxide from the blood than to oxygenate the blood. So this is a major point here. To reach some oxygenation with this ELS device, whatever it is, VV ECMO or ECOR, there is a need to reach a blood flow which is around 3 liters per minute. And then up to 5, 6, sometimes up to 7 liters per minute, the oxygen transfer through the membrane lung is increasing here. And for the most efficient devices, you may reach the patient need, the full patient need for oxygen. CO2 transfer is much easier through these membranes, meaning that even with much lower flows, it's possible to reach some decent CO2 removal. The patient CO2 production in an ICU patient is between 200 and 300 ml per minute. So with this machine, even with lower flows, with blood flows around 1 liter per minute, it's possible to reach 50 to 60% of the total CO2 production of the patient. So we have evaluated this phenomenon in patients on the VV ECMO. Those were patients with super severe H1N1 disease, was 10 years ago. And we did 3 sets of experiments. In the first one, we did decrease the ECMO blood flow, while the membrane FiO2, what is called the FMO2 of DO2, was at 100%. And with the gas flow, which was at maximum, let's say around 10 liters per minute. As you can see here, as the blood flow decreases here, the PaO2 and the blood saturation decrease. So meaning that the main determinant of blood oxygenation in VV ECMO is mostly the ECMO blood flow going through the device. Of course, if you decrease the membrane FiO2, which is called the FM or FDO2, you will also see a steep decrease here in blood oxygenation. And the last slide is also very important here. It's the effect of decreasing the sweep, the gas flowing through the membrane. This membrane is actually kind of ventilator, external ventilator, and the efficacy of this ventilator is mainly determined by the gas flow, which is the tidal ventilation going through this membrane. Very importantly, there is no impact of the gas flow on blood oxygenation. You can decrease the gas flow from 10 to down to 2. Of course, if you cut everything, there's no gas exchange anymore. But there's no impact on the PaO2, while there is a steep here increase in the PaCO2, meaning that the main determinant of CO2 removal in ECMO or ECOR is the gas flowing through the membrane. Once again, this is a membrane, this is a ventilator here. If you decrease minute ventilation, you have hypoventilation, which is another way of creating hypercapnia in these patients. So when looking at the determinants of oxygenation in VV, there might be some device related, and once again, the ECMO blood flow is the main determinant here. In super sick patients, there is a need to reach, using the femoral-jugular setting, up to 5.5, sometimes up to 7 liters per minute to reach full oxygenation. Once again, the membrane FDU2 and the membrane size is important here. When looking for super efficacy, you need to select a membrane for which the surface is close to 2 square meters. You will not be able manage a patient with super severe ARDS, especially COVID or etc., with a smaller membrane here, and might be also patient related, of course. The baseline saturation, hemoglobin, cardiac output, it's here, all the parameters which are counting for the oxygen delivery in a patient. CO2 removal, once again, the main determinant is the gas flow. The membrane size also counts. The blood flow, well, okay, but mostly between 200 and up to 1.5 liters per minute. Beyond that point, there's much less increase. And the baseline PaCO2, if you want to determine what is the total quantity amount of CO2 which is removed by the machine. So when looking at ECMO and ECHO, once again, different types of objectives here. With ECMO, you have full blood oxygenation and decarboxylation, CO2 removal. But you need large cannulas that might be better adapted to large ECMO centers. ECHO, should we show that it has a benefit for patients in the future, might be used in regular ICUs with small machines and lower blood flows. So now, what are the hemodynamic impact of veno-venous ECMO? There is no direct hemodynamic impact. VA ECMO has a major hemodynamic impact on the patients here. There is no direct impact because the blood is drained from a cavity, which is most frequently the right atrium, and re-injected in the same cavity. So there's no major direct impact. However, there is a lot of indirect impacts of the machine, and those are mostly related to, first, the decrease in the intensity of mechanical ventilation, which is allowed by this mechanical lung, which allows you to decrease the tidal volume, the pressure, the respiratory rate, and also reinfusing oxygenated blood through the pulmonary artery will decrease the hypoxic vasoconstriction. And also CO2 removal by the membrane lung will decrease the patient's PaCO2 with higher pH, less acidemia, and a decrease in PA pressure. Altogether, these different mechanisms will lead to a decrease in pulmonary artery pressures, a decrease in right ventricle afterload, better right ventricle to PA coupling, much less need for vasopressors here because there's much less acute pulmonal RV dilation, and there might be also a significant increase in cardiac index just in the minutes following initiation of VV ECMO. This has been shown in a small physiologic study. One of the first was published in the Blue 8 years ago now, showing here the time frame here on the axis is minutes. So it's a very, very rapid effect here. And they measured here the mean arterial pressure, as you can see here, is a steep decrease within minutes after setting up VV, and once again, it's linked to all the phenomena and mechanism I've described in the previous slide. And at the same time, you have an increase here in blood oxygenation. And when looking at percentage of decrease here, there's a major decrease here in the mean arterial pressure in these patients. So this is here the table summarizing all these results. We did a very similar study, which was published in the Blue also a couple months ago now, in COVID patients. Similarly, we showed that with this type of devices, you can control PaCO2, which was almost normalized once again very rapidly. There is a major impact of this control of the right ventricle and the RV coupling, which leads to a decrease in the need for vasopressors. It was also obvious in that study. And on that slide here, you can see that the fractional error change of the right ventricle divided by the mean by the systolic pulmonary artery pressure also significantly improves over the days, meaning that there is a much better coupling between the right ventricle and the pulmonary artery in these patients. And it was also true for the specific RV function here when looking at the free wall strain, which also improved significantly. And once again, despite the fact that you are decreasing the drugs, vasopressors and inotropes in these patients. So those are echo tracings here of patients with severe RV dilation, acute cardiopulmonal. And once again, in less than, let's say, 2 to 3 hours, you will be able to control this problem in severe ARDS patients who had qualified for ECMO. This is why there was a debate, let's say 10 to 15 years ago, what is the better strategy in these patients? Should we go for VV on VA? So the debate has been settled. It should be VV all the time. All the studies showed that there is increased mortality when VA is used here, not to mention the competitive flow I will talk to you about in the second talk. So now we're faced in some very few patients persisting or aggravating RV failure occurring during VV ECMO. So what to do in that situation? You may go for prone positioning. There's some convincing data from meta-analysis showing that prone positioning VV ECMO patients might be associated with better outcomes. Here it's the best evidence we have so far in the 4 studies using careful matching here, and there is a strong trend towards better survival here. It may be linked also to the fact that there may be better hemodynamics in these patients. So we will have the results of the prone ECMO study. Was conducted in France, and the study was finished just last year, and we are just now in the process of analyzing the data. In that specific situation, there is, just to mention, a very specific cannula which may be used if patient develops severe pulmonary artery hypertension leading to RV failure under the ECMO. We have seen that in some COVID patients after 2 to 3 weeks of support, and we now have a specific right atrium to pulmonary artery cannula bypassing the right ventricle. This is both here cannula which allows you to perform veno-venous ECMO plus RV support. This might be more adapted actually to a cardiac surgery department or cardiac ICUs leading with patients with severe RV failure. You can see here the image of the catheter flowing here through the right atrium. The blood is drained here from the right atrium and re-injected in the pulmonary artery. There was one paper reporting on that strategy for COVID patients. And this is my last slide here summarizing what might be the strategy for patients with severe ARDS who have indications for ECMO. Is mostly the Eolia entry criteria. In most situations, it's veno-venous ECMO, which is the solution here. Once again, in those patients who, despite veno-venous ECMO, have persistent or a new onset severe RV failure, this new catheter, although it's very expensive, might be the solution. And it's only for patients who have cardiogenic shock, most frequently as a complication of septic shock in the severe pneumonia, also qualifying for the ARDS diagnosis, for whom you may use VA ECMO or the hybrid form of ECMO I will talk to you about in the second talk. Thank you so much.
Thank you, Alain. Are there questions from the audience? I would like to ask you, what about the impact of blood membrane or other tubings interaction and release of vasoactive mediators?
Yeah.
Is it still relevant with the new devices, or is it something of the past? Or
when looking at the literature, it's mostly something we have seen in the literature from the 80s and 90s. And obviously, when looking at the outcome of patients who are both on VA and VV, and most of these patients are in severe shock, with elevated cytokines, activation of both coagulation and also inflammation. What is seen is that controlling hemodynamics and gas exchange leads to better organ function. It was true also in Eolia, where there's less need for dialysis, less cardiac failure. So altogether, there are many, many indirect proof of better outcomes. And there may be still some activation of what we know is that there's some activation of coagulation, because we see fibrin deposit on the membrane, also thrombocytopenia in these patients. So there's some effect, but the effect on the whole organ system is probably better and more significant than those effects of activation of inflammation and coagulation, for sure.
No question? If not, what could be the impact of the free hemoglobin that is sometimes released on it's on nitric oxide? It will be chelating this. So what would be the potential impact of that?
First, if free hemoglobin is released, if the patient developed hemolysis, there's a major impact on the outcome of the patient, because it might be huge. And in a matter of 10-15 minutes, there might be up to 2 to 3 grams of free hemoglobin released in the blood circulation, because of most frequently is that the cannula, the depression, the pressure in the drainage canal goes too low, because you try to go too high with the blood flow with the cannula, for which the size is limited. And there is an impact. The patient might develop severe acute kidney injury, and this obviously has an impact on the prognosis of the patient. So what to do about that? First, use large cannulas for veno-venous ECMO, and the drainage should be 29 French, especially with these very sick patients we have seen during the COVID pandemic. And second point, put the tip of the cannula within the right atrium. It's the place where drainage is the most easy and with less blood trauma. And monitor on a daily basis serum-free hemoglobin also, because you may see a small increase over days, and this means that probably you have to troubleshoot the circuit, the patient, whatever. It may be an indication also to change the circuit before the patient develops severe hemolysis. But it's a major point also for the daily monitoring at the bedside of these patients.
And yes, there is a question here, please.
Thank you. Astrid Hoedemakers, Nijmegen, the Netherlands. Thank you for your very interesting talk. I was not aware of the possibility to use VPA ECMO. And could you please explain a little bit more what would be the potential advantage to use VPA over VA ECMO?
So VPA, it's fully percutaneous, no arterial cannulation here, and the cannula is passed through the jugular vein into the right heart, the right atrium, goes through the tricuspid, then through the right ventricle, the pulmonary valve, and is positioned into the pulmonary artery. With this cannula, you have full blood oxygenation because there is zero recirculation, because the blood is drained from the right atrium and re-injected into the pulmonary artery. So it has, in theory, a lot of advantages over the VA or VVA or VAV ECMO I will talk to you about in the next talk. The main drawback of that technique, first the cost, just the cannula, the price is for now around 10,000 euro. Yeah, just for one cannula. And the diameter of the cannula is only 27 French, and oxygenation may be limited. We have used this cannula in quite a few patients during the COVID pandemic. Usually those patients develop severe pulmonary arterial hypertension after 2 to 3 weeks of VV. And in one patient, there was a large patient, there was insufficient blood oxygenation because of the blood flow is limited. Although there is no recirculation, the blood flow is limited to 3.5 to 4 liters per minute, and we had to set up another ECMO, FEM-FEM, to reach oxygenation in that patient.